Good. So the next palpations will be the head, neck palpations, and then we'll move from there into the muscles of the neck and then the muscles of the trunk and spine, as well as the sternum. Okay. Your first head and neck palpation is the mastoid process. So I'm going to have Christy kind of rotate a little bit. And remember, the mastoid process is one of your attachment sites of sternocleidomastoid. And it is this prominence just posterior to the pinna, which is the earlobe, right here. So that is the mastoid process. And if you recall, we talked about in lecture that behind that you can feel a slight void, and that is that Eastern medicine trigger point or pressure point for helping you sleep. So if you can't sleep, you're supposed to put your finger there. You can gently rotate or make small circles on it for 30 seconds to a minute bilaterally. And in about 5 seconds, Christy should be snoring.
Yeah, get some lavender in here and I'm out.
So that is the mastoid process. The temporomandibular joint will be slightly anterior to the ear, but not too much. You'll use 2 fingers and then have your patient open and close the jaw. So here, right in front of the ear, I was a little too low. And that is where, and if you watch one more time, you can see actually that condyle right here as it rolls up and then back in. So that's the temporomandibular joint. The next one is the external occipital protuberance, and we already talked about that when we talked about palpating C2 spinous process. And now I want to show you sternocleidomastoid and scalenes. So scalenes, there are 3 scalenes. The only 2 that you have to palpate are the anterior and the middle scalenes. Posterior scalenes is actually deep and really difficult to get to, so it's not a required palpation for you. So we'll start with sternocleidomastoid. And sternocleidomastoid, if I have Christy do the actions of the muscle, that would be to rotation away. And then if you lift your head a tiny bit, you can see and then relax her sternocleidomastoid contract, and that's actually the way you want to find it. So lift and then relax. So this is sternocleidomastoid. Scalenes are classically very tight on human beings. We are hard on our bodies. Scalenes get really tight. The thing to remember about scalenes, anterior scalene runs very close to and slightly posterior to sternocleidomastoid. But if you look at sternocleidomastoid, you will be able to identify the sternal head and the clavicular head of sternocleidomastoid. A common mistake with anterior scalenes is to palpate the clavicular head of sternocleidomastoid and think that you're on anterior scalene, and you're not. So when you do your palpation for sternocleidomastoid, go ahead and lift your head up. This muscle right here that you see is actually the clavicular head of sternocleidomastoid. You have to be lateral to that and slightly deep to that, so go ahead and relax. The the origin of the anterior scalenes and middle scalenes is the first rib. First rib is deep to the clavicle. So this is a vulnerable palpation. Don't palpate one side only over and over again. You will cause discomfort to your peer or whoever you are palpating. So you want to alternate sides so that you cause equal amounts of pain bilaterally. What you have to be able to do to actively feel anterior scalene is get a little bit underneath the clavicle. If you are on I'm going to put my arm in front of your face. If you are on the clavicular head of sternocleidomastoid, you aren't going to be able to get underneath the clavicle. So that's an indicator if you're stuck. And sometimes if scalenes are tight, you won't be able to get under either. But the fibers run longitudinally, and I'm actually right now sitting on anterior scalenes. A little tight.
Mm-hmm.
If it feels super tight and your patient is in pain,
I'm not in pain.
you want to take them out of stretch. So what you can do to feel it better, I'm going to use my right hand underneath Christy's head. Scalene's actions are rotation to the same side, lateral flexion to the same side when they contract unilaterally. So if I want to stretch it a little bit so I can feel it, or if I want to take tension off of that muscle, I can use my knowledge of the actions of scalene to either put a little tension in it or loosen it. Do not do both, lateral flexion away and rotation away, and push down on scalene. It will hurt your patient. Too tender. So 1, rotation away, and then what I want you to do is open your mouth, I know it's kind of crazy, and take a deep breath, the deepest breath you can. All right, and then relax. So what happens is scalene is an accessory muscle, means it helps with inhaling. So if I ask my patient to open their mouth and take a deep breath, deepest breath they can take, they will recruit muscles that are called accessory muscles, and that will be anterior and middle scalene. So that's what I wanted to feel, and I did. So anterior scalene is a little thready and a little ropey on most people because it is so tight. You will feel a little void, not much of a void, but a little void after you move slightly lateral to anterior scalene and deep to anterior scalene. Deep to that void is middle scalene. So if you watch, here is anterior scalene. As I go deep to that and push towards her back, I can feel another thready little muscle, and it's thready in everybody, and I'm going to have her do the exact same thing. So my pressure for the palpation is posterior and under the clavicle just a little bit. Open mouth, take a deep breath. And then I can feel that contract, and actually you can see it elevate here as well. Thank you. So that's anterior and middle scalene and sternocleidomastoid. All right, next is upper trap. Upper trap you would do in sitting, and while she is in sitting, you would just simply have her shrug her shoulders. So when she shrugs, there is upper trap. Okay. All right, you ready for the posterior muscles?
Mm-hmm.
Okay, let's do this. So middle trap is the one that has all the extra kind of motions, and those extra motions are there to reduce excessive overcompensation from primarily upper trap. We all really love our upper traps a little bit too much. So we're going to try to reduce the amount of upper trap and look for some bulk here for middle trapezius. So the way to do that is to have Christy externally rotate, depress her scapula, and retract her scapula. And there it is for Christy right here. So there is middle trap. Thank you. You can relax. Don't do what I just did and leave your patient holding those contractions for very long, because what's going to happen is they'll cramp and they aren't going to like you very much. All right, so lower trap is, and actually, she has started just a little bit of the Wonder Woman, and you can already see surface anatomy. If you look, there is her lower trap right along there. So when she goes up, yep, you can feel that muscle contract and relax. And one more time, and there it is. So that is lower trap. And there's the V that it makes. All right, thank you. Rhomboids, this is the handcuff position. Rhomboid attaches to the medial border of the scapula. And what we want to do is go ahead and pull your shoulder blades down and then squeeze them together. Rhomboid's gonna contract right in here. So go ahead and relax and do that again. Oops, squeeze those blades. There you go. And there is rhomboid right here. And relax. Rhomboids will also get crampy if you make them squeeze too hard for too long. So gentle contraction, your job is really to feel for those muscles as opposed to looking for muscle bulk. You won't always see muscle bulk depending on the patient, but you will feel the muscles contract. That's rhomboid. Latissimus dorsi, right? These are the water wings. So for latissimus dorsi, what I do is go into the axilla and I kind of come up underneath that axilla a little bit. I am not digging my fingers. I can do it on this side too if you want to see it from that angle. I'm not going to dig my fingers into the axilla. I just want to be underneath the muscle tissue. And then, yeah, when she pushes down, I can feel that muscle contract, and that is latissimus dorsi. Okay. Latissimus dorsi, levator scapula we'll do in a minute. Erector spinae would be, and it doesn't matter, you can do this upper body or upper erector spinae or lower. You want to palpate the opposite side, and would you please just lift this leg? When she lifts that leg, these erector spinae should contract and relax. Same thing with arms. If you want to palpate her left side, then her right arm is what you would have her elevate and relax. And again, and you will feel erector spinae. So that's it, except for levator scapula and quadratus lumborum. So I can find quadratus lumborum here. When you palpate quadratus lumborum, it looks a lot like palpating the transverse processes of the lumbar vertebrae. The difference is you have to have your patient do an action for your salient sign. So as you come into finding quadratus lumborum, you have your erector spinae group, and then deep to that is quadratus lumborum. What you want to do is have your patient practice a hip hike. So if she hip hikes and she holds it too long, like she's gonna recruit abdominal muscles. And when she recruits her abdominal muscles, it's gonna push your fingers up and out away from quadratus lumborum. So one thing that I like to do is find the iliac crest and ask my patient to gently, just gently lift that bone that they can feel, yep, up and then down. And then do about 50% of that, even less. And that first muscle that you will feel under your fingers and relax is quadratus lumborum, but it's gonna be kind of deep to erector spinae, just like you're palpating that transverse process. There it is. All right, that's quadratus lumborum, levator scapula. The bane of many existences in A&P1. Folks don't like this. Oh, sternum, I forgot the sternum. Oh, yeah. Thank you. All right, so to palpate the sternum, one of the first things you want to do, because it is a vulnerable spot, is ask your patient to find their own breastbone. Can you show me where your breastbone is? Right there. Is it okay if I palpate that?
Yes.
Okay. So if you have to move tissue, remember you're going to use the back of your hand, and then you'll want to say, all right, there is your sternum. Okay. I don't want to aim in like this. Woo! There it is. Right? You don't have to do that. So I actually just did from, usually I will come from superior in. It feels less vulnerable and they can see my hand instead of the sneak attack from down below, from inferior to superior. So let them see your hand, and then after they palpated their own sternum, then you may palpate the sternum. Okay. All right. Levator scapula. I usually do that in supine. Do you usually do it in supine?
Yeah.
Yeah. So levator scapula is on the superior angle of the scapula, and it goes to the transverse processes of C1, C2, C3, and C4. Its actions, because it is posterior on the back of those transverse processes, it will rotate the head unilaterally to the same side. Yep, and then lateral flexion to the same side. So what I want to do in order to feel it, this muscle, I'm going to show on the skeleton so they can see. So it starts here, just below that superior angle, and it goes to these transverse processes on the posterior side. So it's just slightly off of vertical, a little bit oblique, and tends to be quite thready and ropey and tight in a lot of us. So when you palpate it, you're gonna wanna be perpendicular to those fibers so you can feel that threadiness. And this is what it looks like. I usually will position the patient's head in slight lateral flexion. She's got the little toilet bowl hole here. So. And then I'm going to use fingers together to find the superior angle of the scapula. And I have found that. So now what I'm looking for are threads that stretch in this direction. I'm going to palpate perpendicular to those and find pretty thready muscle that is slightly deep to trapezius. Once I find that, this is what I do with my arm. I'm going to put my elbow, or the kind of my forearm, against Christy's head to stabilize her head. And then I'm going to rest this hand on her shoulder. So I have my palpation fingers on the muscle I think is levator scapula. And then I have support and a lot of contact with my patient. And what I want to say is gently push your shoulder into my hand, this hand that you feel me wiggling. Can you push that? And then relax. All right. When I do that, she will engage levator scapula, and that will cause a little bit of elevation of the scapula, which will contract levator. And you should feel those ropes of levator scapula tighten under your fingers. So that's it.